35-year male presented with redness and irritation in the left eye for last 1 week, and his vision in the left eye is 3/60. His other eye vision is 6/6, and other eye there is no complaints. Fundus examination showed hyperemia of the disc along with blurring of disc margins in the inferior area, and there is no cupping. His color vision is also impaired, and so this is a case of optic neuritis, probably papillitis. Here in the fundus, macula is normal, but disc is showing hyperemia of the disc along with blurring of disc margins. In the inferior area it is more prominent. There is no cupping. So he was started on intravenous methylprednisolone 1 gram per day for 3 days, and his vision is improved to 6/60 on second day. So further treatment include intravenous methylprednisolone for 3 days followed by 1 milligram per kg per day for the next 2 weeks. Papillitis is most common type in children, characterized by hyperemia and edema of the disc associated with peripapillary flame-shaped hemorrhages. Cells may be seen in the posterior vitreous. Neuroretinitis is the least common type, characterized by papillitis plus inflammation of retinal nerve fiber layer and macular star. Retrobulbar neuritis, most common type in adults, frequently associated with multiple sclerosis. Characteristics include optic nerve head is not involved and optic disc appears normal at least in the initial phase. Papillitis is unilateral, papilledema is bilateral, and there is profound vision loss in papillitis with RAPD and vitreous cells, whereas papilledema is bilateral with blurring of vision and pupil reflex is not affected, and marked blurring of disc margins along with peripapillary hemorrhages will be seen. Demyelinating type is most common. It can be associated with isolated or associated with multiple sclerosis or neuromyelitis optica. Infectious causes include endophthalmitis, orbital cellulitis, sinusitis, and contiguous spread from meninges or brain. And systemic causes include viral influenza, measles, bacterial tuberculosis, syphilis, and cat scratch, and fungal cryptococcosis, protozoal toxoplasma, cysticercosis is parasitic. Immune mediated include local uveitis or sympathetic ophthalmitis, or systemic sarcoidosis or Wegener's granulomatosis, or acute disseminated encephalomyelitis. Metabolic causes include diabetes, anemia, pregnancy, and starvation. Following acute episode of optic neuritis, presence of MRI lesion is very strong predictor for multiple sclerosis. With no lesion on MRI, risk of MS is 25%. With one or more lesion on MRI, risk is over 70%. Vision loss in optic neuritis can be subtle or profound, unilateral or bilateral, typically deteriorates over hours to days and reaches through a 1 week maximum vision loss will be there, and vision gradually improves spontaneously. Deep orbital or a retroocular or brow pain aggravated by eye movement increases by pressure on the globe. Neuralgia or headache will be there, and tenderness of eyeball on distal pressure. Tenderness corresponds roughly with the site of attachment of superior rectus tendon. Loss of color vision and reduced perception of light intensity and Pulfrich phenomena, altered perception of moving object seen in unilateral conduction delay, occurs due to relative difference in the signal timings between the two eyes. Systemic features include spinal cord weakness, stiffness, sphincter disturbance, sensory loss, brainstem diplopia, nystagmus, dysarthria, dysphagia, cerebral hemiparesis, hemianopia, dysphasia, and psychological intellectual decline, depression, and euphoria. Signs: decreased vision 6/18 to 6/60, rarely may worse. RAPD or Marcus gun pupil indicating defect in the afferent limb of pupillary light reflex. It is of greater diagnostic significance, tested by swinging flashlight test. Next, decreased color vision, typically red desaturation, abnormal contrast sensitivity, and decreased stereo acuity. Field defects include central scotoma, centrocecal scotoma, or nerve fiber bundle defect or altitudinal defect. Ophthalmoscopic findings: no ophthalmologically visible lesion in retrobulbar neuritis, optic disc hyperemia, swelling of the disc and margins blurred, peripapillary flame-shaped hemorrhages in papillitis, papillitis plus macular fan or star in neuroretinitis. Tortuous veins, retinal veins, exudates on the disc, and vitreous opacities are other features of neuroretinitis. Uthoff sign is worsening of symptoms with exercise or increase in body temperature. Lhermitte sign is electrical sensation on neck flexion. Differential diagnosis include ischemic optic neuropathy, AION resembles papillitis, posterior ION resembles neuroretinitis. Next is papilledema and grade 4 hypertensive retinopathy, Leber hereditary optic neuropathy, toxic and metabolic optic neuropathy, and compressive space occupying lesions intracranial or intraorbital. Clinical verb of careful history include age, rapidity of onset, any previous episodes, and presence of pain or on eye movements, complete ophthalmological vision, pupil reaction, color vision, and fundus examination. Followed by visual field and VEP, prolonged latency is seen, and MRI with gadolinium enhancement recommended for first episode, and every atypical case rule out a space occupying lesion also, and helps in predicting the likelihood of multiple sclerosis. Additional tests in atypical optic neuritis include CRP ESR, rapid plasma reagent, and fluorescent treponemal antibody absorption test, and anti-nuclear antibody test. Clinical course of optic neuritis: in majority of cases, especially those with demyelinating disease, vision starts to improve in the second or third week. By the fourth or fifth week, vision acuity returns to normal or near normal, 680 to 612. Subsequently, vision slowly and steadily improves over several months, ultimately restored to 6/6. Color vision contrast sensitivity, visual fields take longer time to recover, 6 to 12 months, or may not recover completely. Small percentage of cases, vision doesn't improve to functional level, rarely doesn't improve at all, suggesting atypical optic neuritis. Treatment goals of treatment of optic neuritis include to improve the visual outcome. Another goal is to delay the development of clinically definite demyelinating disease. Intravenous methylprednisolone hasten the recovery of visual function but doesn't affect the long-term visual outcome. Patient treated with oral prednisolone alone without IV methylprednisolone demonstrate increased risk of recurrent optic neuritis. Indication of steroid regimen: patient with profound vision loss and no previous history of optic neuritis or multiple sclerosis, and if MRI shows at least one area of demyelination. Steroid regimen include intravenous methylprednisolone 1 gram daily, given slowly over 30 to 60 minutes for 3 days, followed by oral prednisolone 1 mg per kg per day for 11 days, subsequently tapered over 3 days. Observation is the rule if patient has already diagnosed of multiple sclerosis or any atypical optic neuritis. Immunomodulatory therapy reduces the risk of progression to clinical MS in some patients, but risk versus benefit ratio has not been fully defined.